welcome to another edition of Health Matters. I'm your host, Dr. Bruce Karlin, and we welcome you for WCCA TV and the Worcester District Medical Society. Tonight we have a very special guest, Trent Taros from UMass Medical School. He's going to be one of our student interviewers soon to come. I'm quite looking forward. Welcome,
nice to meet
Trent.
you, everyone. Thanks, Dr. Karlin. I appreciate it.
So what we thought we'd talk about tonight is 40 plus years later, Trent's going through. I was a student at UMass. I graduated 1976, and things were quite a bit different. And so Trent and I thought we'd talk about the differences. So one of the differences is that we've had COVID, and to just put a clear picture on the point, during COVID, we are no longer required to wear ties. And part of the reason for that is a British Medical Journal article, if I can ever get this top button off, that said that ties harbor viruses. So there for COVID, new change. I was wearing them until Dr. Broadhurst pointed out that UMass doesn't let you wear ties anymore because of that small but recognizable site of transmission.
It's a meaningful risk. I mean, really anything we could have done, especially during the initial phases and during the several surges thereafter, really any little thing that we could have done, we were really trying to take advantage of, I felt.
Yeah, it sounds good. And we do a lot of that. So I was going to go over some of the differences between my experience and your experience. And we can start with the building. When I was a second, even third year medical student, all our classes were in the tobacco warehouse at the corner of Lake Ave and Route 9. It was referred to as the Shaw Building. We referred to it as the Shaw Building. And we had all of our classes there. A slightly better facility that you're in now.
Yeah, it's slightly better, and it seems like, being upgraded every day, right? I don't know when the last time you were on UMass's campus was. We have this beautiful research building that's currently being built. I think it's going to be completed after my time.
I don't think it will ever be completed. I think they keep they keep doing new things to it. I mean, Dr. Collins has been phenomenal in getting research to the medical school in major fashion.
Yeah, his leadership has been exemplary. I mean, we have Nobel laureates now. We have world-changing research that seems like it comes out every week. I get an email saying, UMass researchers closer to a cure for ALS, all sorts of diseases, rare and not, ALS, type 1 diabetes come to mind especially.
When we were going through, they had the department chairs were doing the teaching, so they hadn't developed their faculty that much. But we had some really good research going at the time. I remember our major thrusts were Fred Fay was doing great research in smooth muscle disease and oh my gosh, we had great research going in osteoporosis and in bone destruction, but we were small, and it's really taken a push of the state legislature saying, hey, this is our flagship. Let's get this thing going. So aside from the size of the school and the other things, I was thinking that among our first interactions with patients, I can remember that Hugh Fulmer, who was our chair and actually the third faculty member hired by UMass, was a major emphasis on family and community medicine. And that was Hugh, who's still with us. He lives up in Northborough and is still quite vital and active. But he had us all go as med students to AA meetings. And at the time we were saying, well, what's that all about? And, years later, having been in practice for quite a bit of that time, you see that he was prescient that is alcohol and addictions are our driving force now in medical care. But we also had other innovations.
And might I say, he wasn't just actually prescient, he was forward-thinking. We actually still do that as an exercise. During our first year, we have a class called DCS, Doctoring and Clinical Skills. And as a part of that, it's required that every UMass student, everyone who matriculates from UMass, at one point in time has attended an AA meeting in order to better empathize with their patients who are struggling with addiction.
And to begin to understand the problem of addiction from a fundamental viewpoint, instead of a lot of my colleagues come at it from, oh, geez, this is a big problem with stuff, instead of saying, I understand what's going on with the patient and understanding it from that end. And to that end, I would say it came a little bit after us, but you guys now study with surrogate patients, and that was actually pioneered at UMass. Dr. Paula Stillman did that early on. She was one of the first people to do it. How have you found that experience?
The standardized patient experience has been almost universally loved. I think getting early access to patient encounters, lifelike patient encounters, during our first years, during really what is in many ways our most formative year of medical school, kind of sets good habits in motion nice and early. And, as real patients are phased in during our second, third, and, fourth cumulative years, you start to see a little bit more phasing out of the standardized patients, and it's kind of a nice transition where you go from almost entirely standardized to almost entirely real patients over the course of your 4 years.
Well, I remember when I was going through and I was telling my colleagues who were at other medical schools that we were actually seeing patients in our first year, that they were absolutely agog. And they said, that's shocking. What's UMass doing? And now in the standardized teaching and the whatever the initials stand for, that the
SP,
medical
standardized patients.
Well, no, I'm talking about the way we do medical education. It's now part of our standardized medical education is to get the real patient experience in. But we started really throwing us to the wolves initially, which was excellent training, but this easing into it that Paula Stillman pioneered and UMass really had blossom is really the way for the country. We're way ahead in the way that's done.
I agree.
The other thing is that we used to have to sit through interminable lectures. The whole idea was, we'd get into the Pshaw building, we'd have a couple of classrooms, you'd have your biochemistry professor come, and I can remember our biochem professor, Dr. Butcher, used to teach with a hockey stick, and he'd write the stuff up and point to the board with the hockey stick, but that was just to keep us awake, and now you can sleep right through them. And how do you get them? How do you generally go? Do you go to class or some mixture of class and watching them on tape?
So it's a great question, and I think actually how I envision medical school is different from how I've actually experienced medical school. So I'll say that all 4 years of college, I went to almost every single lecture. My parents, I was maybe one of the few people that my parents thought should have skipped a couple of more classes to have a little bit more fun. But at medical school, I went to classes religiously for the first couple of months, and then I discovered that I wanted to learn on my own time. And so one of the nice things that our school does is that they record all of our lectures. So you can either watch them live, you can live stream them, or you can watch them recorded about an hour to an hour and a half after they happen. I found personally that I didn't mind being 2 or 3 days behind the class. I knew that I could catch up, and it let me be a little bit more flexible in my schedule, especially when I didn't want to make the 8 a.m. biochem lecture, the 8 a.m. immunology lecture that, as you can probably attest to, goes on for seemingly 10 hours.
Yeah.
There's a lot of that. There's a lot of outside resources that get used as well now. Medical school has, in a lot of ways, become crowdsourced. There are some phenomenal resources. Some of us joke that we learn a lot of our microbiology from these cartoons called sketchies. We kind of have an in-joke among future physicians that in 50 years we'll all be yelling at each other about, where certain objects were in the cartoon as it was going along. There's been a lot of change, I think, in the last decade especially. I think that the internet has really revolutionized things quite a bit. But I think that it's all for the best. I think that doctors are generally learning more and more efficiently than ever before.
And you don't need to retain as much. So a lot of stuff was rote that was unnecessary rote. I think back to my biochem classes, and we learned Krebs cycles and things like that.
Oh, I promise you still learn the Krebs cycle.
Yeah, but you don't use it ever again. It's
Yep.
it's one of those things. How many ATPs can you crank out of the Krebs cycle, and then you say, geez, maybe you'll see one patient with McArdle syndrome or something, and
yeah.
you say, oh boy, I better look that up. But I think we all depend on up to date for our clinical knowledge, and we don't use textbooks the way we used to.
I agree. Textbooks, with some exceptions, with some notable exceptions, there are classics that are, I think everyone should read, that I think are great textbooks, but for the most part, as a reference material, I agree. I mean, we're all using it to date.
A lot of the clinical stuff doesn't change. The symptoms and signs
Yep.
are still, when written up well as they were with some of the old textbooks, that's a great way to read it. But Up to Date also has its origins in Worcester. So Bud Rose, was actually our nephrology professor. He was the head of nephrology at St. Vincent's when I was going through there. And he is the founder of Up to Date. Unfortunately, he's passed since then, but he was, he had been the editor for Scientific American Medicine, which had the idea that they'd send you constant updates. And he said, so why are we doing this on a publishing basis? Why don't we do it on the internet? And that was his insight. And he started Up to Date, and he got a stable of great editors, and said, just keep updating it daily. If you've got something new that comes in today, and you can vet it and put it forward, and that's what Up to Date is. It's just, the constantly updated textbook, and everybody uses it across the country, across the world.
Yeah, I mean, it's
Worcester.
incredible. Worcester. I love it. I had no idea.
Yeah, Bud Rose. We used to play basketball with him. He was wonderful.
That's fantastic.
So, getting back to studenting, I guess every few decades we have another problem that rears its head. In our day, after we went through, AIDS came
AIDS
along.
and HIV.
And we used to sit there initially, and you just watch these patients die, and this was your treatment. Was, oh my
Call the
God.
chaplain.
Yeah, and and while you were going through, of course, you had 2 years of AIDS, of AIDS equivalent COVID, which is even killing far more patients. So what was it like? What were your experiences with COVID as a student?
It was difficult. It was difficult in every way that something can be difficult. It was difficult to sit and to watch patients go through that. I was in a unique situation in that I was about to become a third-year medical student. I was about to take my first set of licensing exams when the first wave happened. You know, at that point in your medical career, as you may well remember, you have a lot of the book knowledge. In fact, you have almost all of the book knowledge, but what you don't have is the clinical knowledge. You don't have the ability to manage a patient. You don't have the
Application.
the application part of it. Exactly, well said. And so it was frustrating to have all of this medical knowledge, you know, to know about the spiral capsid of the coronavirus, but to say, what the hell does that matter? Exactly. And, you know, then it became frustrating when there were patients that we couldn't see initially on rotations who had COVID. And then it got progressively better as we got better at treating it. People got vaccinated, people were compliant with masks, people were able to do what was best for them to limit their exposure, and if they did catch COVID, they knew to quarantine and to stay in and to limit the spread. And things got better, and things got better for everyone, I would say, but you know, as a medical student who went through this, I'm especially appreciative to the public because things got much better for me. And much better in so many ways, from, you know, not having the emotional baggage of having the patient that you saw in the emergency department die in the ICU several days later to, you know, being able to see my classmates again, something as simple as that. So I truly am appreciative to all the basic scientists, the clinicians, and the public for doing what ended up getting us out of this pandemic, or as close to out as we are now.
I would point out that the leadership at UMass pushed a bunch of med students out into, graduated them a little bit early so that we could have more physicians to deal with this, which I thought was impressive. It was brave. It was a bold statement by UMass, you know, my alma mater.
You know, we talked about Chancellor Karlin's leadership, and I think that was perhaps one of his signature moves as our chancellor here. I completely agree with every word you just used to describe that. I think it was brave in a lot of ways, but I think it was the right thing to do. I personally know several of those students, and they felt like it was one of the more meaningful experiences of their early, albeit but still their careers thus far.
So you moved from COVID to making you're making some career choices now. I don't know how long we're going to have you, but Trent, we're hoping that you can host a couple of shows from the medical student perspective. But maybe we can spend a moment talking about you, since you're going to be
Sure.
one of our hosts. You were originally interested, I think your focus was on prostate cancer, and were thinking of urology until you discovered that the interventional radiologist might have had a better track on how to treat prostate cancer than the surgeons.
Well, I don't know about better just yet, but one of the things I love about interventional radiology is that...
So that's where you're headed.
That is where I'm headed.
You made the switch. You thought you were going to do surgery, but then you said, oops.
Exactly. I think there's a lot of parallels. I love the minimally invasive approach, and frankly, especially at UMass, but everywhere around the country as well. Interventional radiologists are sometimes the last line of defense. If you have a sick patient who's on 3 pressors, um, you know, that patient, if that patient needs an abscess drained, he or she is not going to surgery. They're probably going to go to interventional radiology, and that's what excites me, is giving those really sick patients a good chance.
So also you get great toys.
You do get great toys, yeah. You can't underestimate the fun of toys, huh?
I recently had a patient that the neurointerventional radiologist cured. Dr. Puri did an amazing job on getting into a tiny vessel in the brain and curing a patient, which was astounding. In the old day, you would have had to do a major fillet of patient in order to get there, and the cure would be worse than the disease. And here, you're doing amazing things. So you're going to take a year between this and whatever fellowship you do to do some study, I take it.
Yep, that is absolutely correct. I'll be splitting my time between the University of Massachusetts and Brigham and Women's.
It's easy for you
tongue
to
twister,
say.
I know. To do research in diagnostic and interventional radiology.
Now let's talk about some of your other experiences as a student. We were a very close-knit class because there were only 24 of us. We used to hang out. 6 of us lived in one house together. So with 2 or 3 others in the class generally coming over to do stuff. When we were going through, Chancellor Souter and Dean Saunders, who was our the dean of students, actually would occasionally come. We would have them for dinner at our house, and Chancellor Collins is awfully accessible, but it's not quite the same. I mean, we were, maybe the entire population on campus was 200. Now there are thousands of people up there, a lot of them in the research facilities. How do you feel about your contacts with the deans and with the rest of the faculty?
So in terms of faculty, I think we have, I will preface this by saying I've only ever been to one medical school. But I think that, honestly, we probably have better than average access to our faculty and our kind of upper tier leadership. Chancellor Collins and Dean Flott both make big points out of meeting every single first year, getting to know you as much as they possibly can. I mean, they're 2 very busy guys, but they do a great job of meeting you. We have excellent mentorship here. I think some of the best. We have assigned mentors. I'm, of course, partial to mine, Chris McGinnis, best mentor out there, no question.
Best one of all of them, right?
Best one of all of them, yep.
Yeah.
You can quote me on that.
Yeah.
But we do have great mentorship, no matter what you're interested in. One of the great parts of going to a school that's affiliated with a large hospital system like ours is that almost no matter what your interest is, you'll be able to find somebody who shares that interest and really is passionate. They work at the University of Massachusetts typically because they're passionate about students.
So you may actually have, now I note that Chancellor Collins and Dean Flott both show up at our medical society on a very regular basis, and the faculty at UMass has been very involved with the medical society, so that the parts of medicine that people don't see, that have to do with how we interact with the community at large and write social policy. I think UMass has been outstanding at doing that. I would say that's probably not changed that much. I mean, Dean Souter and Chancellor Souter and Dean Saunders were very active in that. I wonder how do you picture your role in getting some med students to talk about what experiences do you think that the med students have that you would like to share in future shows with us?
I think that probably more so than ever, students are just coming from all sorts of backgrounds. I am maybe one of the more traditional medical students in that I came straight through from college. I studied biochemistry in my undergrad. But that's really not the norm anymore.
You went to every class.
And I went to every class, yes,
class.
Exactly. But that's just simply not the norm anymore. I think that people have all of these experiences, whether it was traveling for years before medical school, majors. There are majors in my class from everything you can think of, from psychology to finance to I believe we have a dance major in my class. It truly is all over the place. And then as well, students are doing more research than ever. I know that I personally am doing more research now than I did before. I'm taking a research year, of course, so I enjoy it. But almost every medical student has at least one publication in their time at UMass. And it's almost always about something that they're passionate about. And it's almost always something that makes you think. And I think that giving people the ability to share that with the community, I think that would be really impactful.
It's sort of fun. It's sort of like with the surrogate patients that we use. People don't realize that you actually get feedback from, and it's generally actors that act as the surrogate patients. And these, you don't think of actors as being helpful in what we do, but they're trained in reading emotions and portraying emotions. And they pick up on the silly things that you do when you're interviewing patients, and they tell you about it. And it's help that you don't get otherwise. And so I think those varied experiences also help. Well, I think we've used up the time. Well, I would like to again thank Trent Taros for being our guest. I would thank you to Frank Rocco, our engineer, who is steadfast and good as always, and say thank you for watching Health Matters with WCCA TV and WDMS, Worcester District Medical Society. Thanks again for watching.